Hi, my name's Henry, one of the radiology registrars working at SA Medical Imaging, and we're just talking about the shoulder today. So some of the aims of this lecture and how they relate to the learning outcomes. We want to understand and explain the utility of different types of imaging modalities in musculoskeletal imaging of the shoulder, usually today talking about mainly plain films, ultrasound and MRI. And then we'll be talking about different musculoskeletal conditions, fractures of the clavicle, scapula and humerus, SC joint, AC joint and shoulder joint dislocations, and then a brief talk about the anatomy of the rotator cuff and some of the associated pathologies, and then another brief talk about different types of shoulder replacements. So this is an AP projection of the right shoulder. So we can see the humeral shaft. We've got the surgical neck of humerus. We have the greater tubercle and the lesser tubercle, anatomical neck of humerus, head of humerus, the glenoid cavity, glenoid fossa. We've got the Corocoid process of the scapula, the acromial process, the Acromioclavicular joint, clavicle. We've got the spine of the scapula, and the right ribs and right lung. On this projection, we can see the sternoclavicular joint and the superior angle of the scapula more readily as the inferior angle of the scapula. So talking about the sternoclavicular joint and its main pathology of disruptions. So the sternoclavicular joint is a synovial joint. It has very strong supporting ligaments, and as such, injuries are relatively uncommon and associated with severe blunt chest wall trauma or motor vehicle accidents. The sternoclavicular joint can be dislocated anteriorly or posteriorly, and can be graded from, like I said, from strains to complete dislocations. Important to note that posterior dislocations can be, or disruptions can be associated with life-threatening injury. We have the brachiocephalic veins and the great vessels arising and traveling just posterior to the sternoclavicular joint. We do angled views as well. Inferior displacement of the medial head of clavicle suggests a posterior dislocation, and superior displacement suggests an anterior dislocation. Treatment can be anywhere from conservative for sprains or strains to closed reduction to open reduction and internal fixation for irreducible posterior dislocations. So this is demonstrating an anterior sternoclavicular joint dislocation. On the left on this plane radiograph, it's moved superiorly, and on CT we can see on the right we have the medial head of the clavicle dislocated anteriorly to the and is associated with a fracture as well of the medial head of clavicle. This is usually through an indirect action, like a blow to the shoulder, and can cause a palpable deformity, as opposed to a posterior dislocation, which may not be evident clinically, but like I said, can be associated with severe life-threatening injuries. We can see here we've got the left medial head of clavicle, which is inferiorly displaced, suggesting a posterior dislocation, which is confirmed on CT. And important to note is that we've got the left brachiocephalic artery, which is arising soon after it's arisen from the aortic arch, which is just behind this sternoclavicular joint on the left. Other important things like trachea and lung as well. So clavicular fractures are relatively common. They account for approximately 5% of all fractures. Majority of and typically they result as a direct blow to the shoulder. Majority of them occur either in the midshaft or at the junction of the middle third and outer third, as it's the thinnest part of the bone with less soft tissue support. The standard clavicular series includes a frontal and a 30-degree up tilt projection. And it's important to not only report on normal things like location and angulation, comminution degree of overlap, but to take a careful look at the acromioclavicular joints and sternoclavicular joints. Usually it's treated with immobilization, but indications for open fixation would be if there's skin compromise or tenting, neurovascular injury, or significant displacement. Acromioclavicular joint injury is usually traumatic. It's either direct from a direct blow to the shoulder with an adducted arm, which results in superior force on the acromion, or indirect from full on an outstretched hand or elbow where the humerus is pushed into the acromion, usually results in lower grade injuries. So on a plain, on a frontal radiograph, we can measure the acromioclavicular distance and the corococlavicular distance. And normally the inferior margin of the clavicle would line up with the inferior acromion. It can be helpful to compare affected and unaffected sides, as there's a sort of a wide degree of quote-unquote normal, and stress views can help in delineating AC joint injuries. They're graded by the Rockwood classification. So this is the Rockwood classification or grading system for acromioclavicular joint injuries. Type 1 injury can be subtle or not apparent at all on radiographs. You can sometimes see a bit of soft tissue injury, and that's where there's a sprain of the AC ligament and a normal CC ligament. Grade 2 injuries where the clavicle is elevated but not above the superior border of the acromion. It's where the torn AC ligament and a sprain of the CC ligament. Type 3 injuries where the clavicle is elevated above the superior border of the acromion but less than twice the normal distance, or the CC distance is less than twice normal, and you've got a tear of both the AC and the CC ligaments. Types 4 to 6 is again tear of both ligaments, but it's where the clavicle is located. So in type 4, it's located posterior to the trapezius. Type 5, significantly elevated with CC distance more than twice normal, and type 6, where the clavicle is inferiorly displaced, sort of behind coracobrachialis and the biceps tendon. No, couldn't find a picture of that one. Treatment depends not only on the type of injury, but the sort of age and lifestyle of the patient. Generally, type 1 and type 2 injuries are conservative. Types 4 to 6 generally surgical, and type 3 is a bit variable. Scapular fractures can involve sort of any part of the scapula, body, sort of the glenoid. It can be interarticular glenoid or extraarticular glenoid, the neck of the scapula, spine or acromion or coracoid processes of the scapula, and can be not always visible on x-rays, but can be associated with significant trauma or an indication of high energy trauma. 50% of scapular fractures occur in the context of motor vehicle accidents, and can, like I said, can be associated with other injuries as well. So clavicle, rib, sternal fractures, spinal fractures, pneumothoraces, lung contusions, or brachial plexus injuries. Most commonly seen on CT chest in the setting of a trauma pan scan. So some normal scapular anatomy. So this is an anterior view of the scapula. We have the medial and lateral borders, the inferior and superior angle in the superior border. And we've got the glenoid, the coracoid process, and the acromion coming behind as a sort of the continuation of the spine of the scapula, which we can see on the posterior view. We also have a supraspinous fossa and an infraspinous fossa, which we'll talk about more when we talk about the rotator cuff. So these are just x-rays and 3D reconstruction of CT demonstrating a scapular body fracture, where we've really the inferior angle of the scapula has been fractured up, and it's comminuted. And we can see the same on CT here, so inferior to the spine of scapula, we've got a comminuted fracture of the body of the scapula. Here we've got a fracture of the acromion, which is displaced. So this is the medial portion of the acromion and the lateral portion, and this is the displaced so the degree of displacement, and a displaced and angulated fracture of the Corocoid process. So the Acromio-humeral interval is important in talking about in both shoulder dislocations and also rotator cuff pathology. Normally measures 8 to 12, and it can be sort of reliably measured on a true frontal radiograph. Greater than 12 millimeters, you're thinking dislocation or subluxation. Less than 6, you're thinking rotator cuff pathology. And in severe rotator cuff pathology or complete supraspinatus tears, there can be complete obliteration of the acromio-humeral interval. Like I said, normal is about 8 to 12 millimeters, and in a chronic rotator cuff tear, we've lost that interval, and there's sort of associated arthropathy of both the humeral head and the acromion. So shoulder joint dislocations, the vast majority of these are anterior, about 95%, with posterior and inferior being rarer. So like I said, anterior glenohumeral joint dislocations are the most common, and usually as a result of indirect force from abduction, external rotation, and extension. Things that can predispose to anterior shoulder dislocations are a flattened or shallowed glenoid contour. Typically, on radiographs, the humeral head is seen inferior and medial to the glenoid on a frontal projection, and a scapular Y or lateral projection will show this sort of the anterior dislocation. There are some complicating fractures or soft tissue injuries that we'll talk about in a second. Typically, these are managed with closed reduction, a short period of immobilization, and graded physiotherapy. So when we're describing anterior shoulder joint dislocations, you can also describe them in terms of the structures that are nearby, so subglenoid dislocation, subcorocoid dislocation, or subclavicular dislocation. So on radiographs, we can see that the humeral head is displaced medially and inferiorly on the frontal projection, and on lateral we can see it's anteriorly, or on the scapular Y view we can see it's anteriorly dislocated compared to the glenoid fossa. This is how we present clinically. So like I said, there are a couple of complications. A Hill-Sachs fracture is a fracture of or an impacted fracture of the posterolateral humeral head, where it impacts the anterior rim of the glenoid. A Bankart lesion is the corresponding injury to either the glenoid labrum or the glenoid itself, which is termed a Bony Bankart. Injury to the glenoid labrum, you need an MRI to see. Other complications could include a inferior glenohumeral ligament injury, which could predispose to instability and repeat dislocations, or damage to the axillary artery or brachial plexus, which is around the same area. So this is Hill-Sachs fracture, as we were talking about. So this is while the humeral head is still dislocated, we can see that the posterolateral humeral head is butt up against the anterior inferior glenoid, and it's caused this depression fracture of the posterolateral humeral head. And this is just a CT and X-ray of a Bony Bankart injury, where we've got a fracture of the anterior and inferior glenoid labrum. This is after relocation. Posterior shoulder dislocation are much less common than the anterior dislocations, and it's usually due to either direct or indirect trauma. It has been sort of described as being due to sort of posterior force while the arm's in internal rotation while it's abducted, and described in the setting of convulsive disorders or electrocution. It's best seen on an axillary or lateral view. Oblique views can sometimes help as well. On frontal projections, things to look out for are light bulb appearance of the humeral head, which is due to internal rotation of the humerus, which takes the normally visible greater and lesser tubercles and rotates them so that they can't be seen. So you get a light bulb shape of the humeral head. If you see the humeral head superior to the glenoid, that can clue you in. And other things like a trough sign, which is a compression fracture of the anterior humeral surface, or a sharp angle of the scapular-humeral arch, which is kind of the shoulder equivalent of Shenton's line in the lower limb. So light bulb appearance of the humeral head, because we're not seeing the greater or lesser tubercles in profile. So it looks like a light bulb. We've got a trough line sign here, which is a fracture of the anterior humeral head. On the lateral views, we can see easily that it's posteriorly dislocated, and then the other thing is the sharp angle of the scapular-humeral arch. So usually this the lateral margin of the scapula, lateral border of the scapula, and the sort of inferior margin of the humeral head and humeral shaft makes a nice smooth angle. Here we can see it's sort of more acute. But auxiliary view, it's really easy to see. This is that oblique view, so it's a 40-degree oblique view where we've got loss of glenohumeral space from the as compared to the frontal projection, which is sort of diagnostic of a posterior dislocation. By far the least common is an inferior dislocation, which is caused by hyperabduction of the arm, and patients will present with their arm held up in abduction, sort of with their hand on their head. And the humeral head here is displaced below or medial to the glenoid fossa. It's got a pretty high complication rate, both neurovascularly and with capsular injury or rotator cuff disruption. So this is how they present, with their sort of arm above their head and the hand on their head, and that humeral head is inferiorly displaced compared to the glenoid. So something to not get tricked by is a pseudodislocation or pseudo-subluxation, which is where there is inferior and lateral displacement of the humeral head, either due to a large shoulder effusion or a hemarthrosis. It's not a true inferior dislocation. So here we've got a fracture of the proximal humerus, a comminuted fracture of the proximal humerus, and we've got this soft tissue density sitting here. We've got a fluid level, which suggests that this is a lipohemarthrosis with the less dense fat sitting on top of blood, and that humeral head is pseudo dislocated or inferiorly displaced compared to the glenoid, but not truly dislocated. Proximal humerus fractures are more commonly seen in osteoporotic patients following a fall on an outstretched hand. Most of them are non-displaced, but can be classified based on how many displaced fracture fragments there are. So the Neer Classification is probably the most used classification, which divides the proximal humerus into 4 segments: the humeral head, greater and lesser tubercles, and the humeral shaft, with displacement defined as greater than 1 centimetre of separation of fragments or greater than 45 degrees of angulation. So, like I said, the humeral head or the articular segment, the greater and lesser tubercles, and the humeral shaft. And then it's classified as a 1 to 4 heart fracture based on the degree of displacement of the fracture segments. And this is just a sort of diagrammatic representation of that previous table. Here we've got a greater tubercle, an isolated non-displaced fracture of the greater tubercle, and then a non-displaced anatomical neck of humerus fracture, or maybe slightly superiorly displaced, and a surgical neck of humerus fracture with comminution and some angulation as well. It's a comminuted 3-part Neer fracture. We've got displaced or multiple displaced fracture fragments of the articular surface, the greater tuberosity, and the humeral shaft. So before we talk about rotator cuff pathology, we'll quickly go through some of the anatomy. The way I remember rotator cuff muscles is with the acronym SITS or SITS. So starting with on the posterior surface of the scapula, it's divided into the supraspinous fossa and the infraspinous fossa by the spine of the scapula. The supraspinatus sits in the supraspinous fossa and is involved in abduction of the humerus. The infraspinatus and teres minor in the infraspinous fossa, the teres minor originating sort of on the lateral border of the posterior scapula, both involved in external rotation of the humerus, and on the anterior surface of the scapula, it's sort of adjacent to the thoracic cage, is the subscapularis. The supraspinatus, infraspinatus, and teres minor all insert on the greater tubercle. Supraspinatus inserting on the superiormost facet, infraspinatus on the middle facet, and the teres minor on the inferior facet. Subscapularis inserts onto the lesser tubercle. They're all innervated by the suprascapular nerve, which is a branch of the brachial plexus, except for the teres minor, which is innervated by the axillary nerve, also from the brachial plexus. So diagrammatically, what we've talked about, on the anterior surface of the scapula, which is against the thoracic cage, we have the subscapularis with tendons inserting on the lesser tubercle. In the posterior view of the scapula, we've got the spine of the scapula separating it into a supraspinous and infraspinous fossa. The supraspinatus has its tendon passing under the acromion, under the acromioclavicular ligament to insert on the superiormost facet of the greater tubercle. The infraspinatus arising from the majority of the inferior border, the inferior infraspinous fossa, and inserting on the middle facet of the greater tubercle. Teres minor on the lateral border of the and inserting on the inferiormost facet of the greater tubercle. So this is looking at sort of a sagittal view of the humerus and with the subscapularis anteriorly, infraspinatus and teres minor posteriorly, and supraspinatus superiorly. The relation of the supraspinatus, the acromion, and the Corocoacromial ligament is important when looking at supraspinatus pathology and sort of impingements and bursitis and things. So this is helpful again in looking at the relationship of the supraspinatus muscle and tendon to the Corocoacromial ligament, the acromion, and also helps to delineate sort of where the long-headed bicep tendon sits in the biceptal groove. Now to talk about rotator cuff pathology. Rotator cuff injuries are relatively common, and they range from impingement, which is a limitation of joint motion caused by protruding soft tissue or bony structures, which cause entrapment of soft tissue resulting in pain. Tendinosis, which is a chronic degradation of tendon with damage at a cellular level. Bursitis, which is inflammation of a bursa in the shoulder, most commonly the subacromial and subdeltoid bursa. A bursa is a synovial membrane-lined space which overlie or present in a number of joints, overlying joints and tendons, allowing tendons to slide over each other. Calcific tendinitis, which is a deposition of calcium hydroxyapatite within tendons. Rotator cuff tears, which can be both partial or full thickness. Adhesive capsulitis, which is thickening and contraction of the shoulder joint, capsule, and synovium. There are a number of modalities that these are imaged on. Radiographs have their place. Ultrasound can be helpful in sort of dynamic assessment, and MRI as well, with its great contrast resolution. Tendinitis is an inflammation of the rotator cuff tendons. It can often be associated with impingement. On an ultrasound here, we're seeing thickening and edema within the supraspinatus tendon. And on MRI, we've got a subtle sort of high signal intensity at the supraspinatus insertion, high T2 signal intensity, so fluid signal. Impingement, like I said before, it's a limitation of joint motion caused by protruding soft tissue or bony structures which cause entrapment. Primarily, it's a clinical diagnosis, although radiographs or MR may depict causes or things that may predispose to impingement. Things like a flat acromion, accessory ossicles, osteophytes, a reduced acromio-humeral interval. Ultrasound can depict abnormal contact between the coracoacromial arch and tendon structures, and is particularly useful for dynamic assessment. Most commonly affects the subacromial space, which can lead to tendinitis or bursitis, but can also be subcorocoid, affecting the subscapularis, or posterior superior, involving the infraspinatus. Subacromial bursitis is inflammation of the subacromium subdeltoid bursa, which is a bursa that separates the superior surface of the supraspinatus from the overlying coracoacromial ligament, acromion, corocoid, and the deep surface of the deltoid. Risk factors include repetitive overarm motion, so people who like baseball pitchers, tennis players, I think it was described in spear throwers at one point, manual labourers, but can also be caused by acute trauma or rotator cuff injury, and is associated with rheumatoid arthritis. People present with pain and point tenderness under the acromion. Ultrasound at the bottom here demonstrates a fluid-filled and distended structure with a hyperechoic wall, which represents synovial hypertrophy. The MRI demonstrates a fluid-filled structure between, or can demonstrate a fluid-filled structure between the supraspinatus tendon and either the acromion or the subacromial space, or between the deltoid. Calcific tendinitis is the deposition of calcium hydroxyapatite in the tendons of the rotator cuff. Plain radiographs, you can see calcific deposits where your supraspinatus tendon would be, and on ultrasound, echogenicities with posterior acoustic shadowing suggesting calcification. So rotator cuff tears can be secondary to injury or degeneration over use. Can be full or partial thickness, and it's most common in the supraspinatus. As we've already discussed, plain radiographs can demonstrate a reduced acromio-humeral interval, and ultrasound and MRI can distinguish between full or partial thickness tears in the tendon. On ultrasound, we can see here in the supraspinatus tendon, there's an area of the tendon that's completely ruptured, or there's a full thickness tear with fluid replacing the tendon. Partial tears would be evident as a hypoechoic or anechoic defect in the tendon that can either be either on the articular side or the bursal side of the tendon, so extending to the articular surface here or the bursal surface here, or you can have intrasubstance tears, which are focal defects within the substance of the tendon itself. Similar findings on MRI, though partial thickness tears are more difficult to appreciate, where you've got replacement of the tendon by fluid signal indicating full thickness tear in the supraspinatus. So frozen shoulder can either be primary or idiopathic, or secondary to major trauma or minor repetitive trauma, can be post-surgical or associated with endocrine abnormalities like diabetes or hypothyroidism, and is also associated with some rheumatological conditions. Patients present in one of three phases. The first phase is the painful phase, where there's worsening restriction of active and passive range of motion, and represents acute synovitis of the glenohumeral joint, lasts anywhere from 3 to 9 months. Then there's a transitional phase where the pain doesn't necessarily worsen, but you have your range of movement remains limited, and that can last anywhere from 4 to 12 months. And there's a thawing phase where you have gradual improvement in range of motion over sort of 12 to 24 months. On imaging, this is usually seen as a decreased size of the joint capsule with obliteration of axillary and subscapular recesses. You can also see on ultrasound or MR thickening of corocohumeral ligaments in the joint capsule itself. And on plain radiograph, you can, because of the lack of range of motion, you can get disuse osteoporosis, so a reduction in bone density secondary to disuse. So on MRI, we've got the normal axillary recess up the top, and in adhesive capsulitis, we have obliteration of the normal axillary recess. And just a quick discussion on shoulder prostheses. So a total shoulder replacement consists of a replacement of the humeral head and glenoid resurfacing. It can be performed because of severe shoulder damage, which can either be degenerative or traumatic, but requires the rotator cuff to be intact. Hemiarthroplasty is where the humeral articular surface is replaced with a stemmed humeral component. This is a stemmed hemiarthroplasty, as opposed to just a resurfacing hemiarthroplasty where we have a humeral head after the arthroplasty and the prosthesis is not stemmed. This can be indicated where there's abnormal humerus anatomy. And a reverse total shoulder replacement where we have reversal of the normal ball and cup joint around the shoulder. So we've got a convex glenoid and a concave humerus. This moves the center of rotation inferiorly and medially and provides the deltoid with a greater mechanical advantage. So it can be indicated in rotator cuff tear arthropathy, 4-part Neer fractures, and failed arthroplasties. And that's our talk on the shoulder. Thank you.